Okay, ladies and gentlemen, you're about to receive the world's first international medical podcast, hosted by 3 paramedics from different countries. Live from the UK, Finland and Australia, this is Group Call.
Hi guys, and thank you for tuning in. Group Call. Today we're going to talk about intubation. Is intubation a kind of a mythical animal, a dragon, a monster that actually should be removed from pre-hospital clinicians' scope of practice? Or maybe actually it's a quite valid procedure that should be actually in our scope of practice, but for any reasons, I don't know why, it's being withdrawn from pre-hospital clinicians. Let's ask some difficult questions then, and let's talk about intubation today. Straight from Australia, Harrison Steeds. Straight from Finland, Timo Silva. And live from the UK, Alex Hepner. Hi guys, you alright?
Excellent, how are you?
Perfect. No, not too bad. Thank you. Guys, let's get started because we had a small technical problem and we didn't start, the stream didn't start actually on time, but now we are with you. So without further ado, let's get started. On the very beginning, I'm going to talk a couple of words about intubation. I'm going to say a couple of words about intubation because what I've learned very recently is that there are couple of young clinicians out there who have no idea what intubation is, and it is not because they are not educated. It is because some universities in this country are not teaching intubation anymore. So there are clinicians out there or students, paramedics who don't really know what the intubation is. So guys, for you and only for you, a very brief explanation, very simplistic explanation of what intubation is. So the intubation is a way of securing an airway with the patient, where you use the tube and you slide the tube down the patient's throat to the trachea between the vocal cords, and then you secure it with a cuff. You pump the balloon, you inflate the balloon. There is a cuff on the end of this tube, and then you secure the tube with the cord or place or tube holder, depending on the authority you work for. Now, and then you just ventilate your patient. Again, the tube goes into the trachea. It doesn't sit on the top of glottic opening as it normally sits with the supraglottic airway. You know. Now, there are a couple of things you have to remember when you intubate your patient. You need to insert the tube on the correct depth. So for ages that was 21-23 rule, which is a clinical bullshit. Let me say that. Those numbers were derived from a study that actually was like 85 patient sample, and all Caucasian and all males were taller than females. So this is not the correct depth, not 20, 21, 23. You want to use the Chula formula, which is actually your estimated patient's height times 0.1 plus 4. And I will leave the whole study on the Chula formula. The link will be in the description to this video. So that's the depth of the tube. Now you also have to remember to inflate the cuff or inflate the balloon if you like. And normally, very old school bad way was 10 mils of air, push straight to the balloon, and that was fine. Which is not actually the correct pressure of the cuff. Should be checked with either manometer or a special syringe, which basically gives you the proper pressure in the cuff of the intubation tube. If you will overinflate the cuff, it can have a bad consequences for the patient, because overinflated cuff may cause a tissue necrosis and maybe subsequently sepsis. In order to get a good view and slide the tube down the patient's throat and trachea, you need to use laryngoscope or a different device that we will talk about slightly later. And basically that's it. Then you secure the tube, then you check your patient's chest rise and fall, ETCO2, and you auscultate bilaterally, and that's your patient's airway secured. Many people think that it's a bad skill, that this skill should not be taught anymore because it's very complicated. Some people think that actually it's not that bad and it should be used. And I'm this person. And again, I know that Timu is laughing because I have this thing, the intubation, or taking away the intubation from pre-hospital clinicians massively triggers me. So today I'm going to fight with Timu, who is slightly more critical towards intubation, and Harrison will be our blue helmet, our United Nations to keep us apart. Also on the show we'll have a special guest. Slightly later we will introduce our special guest, or actually he will introduce himself. However, that's a bit later in the show. That was a very brief introduction and very brief and simplistic description of intubation for those clinicians who have really no idea what the intubation is. Is it widely used in pre-hospital setting? It depends on the country, and actually it depends on the authority. So in the United Kingdom, where I live and work at the moment, some authorities, and we have 11 ambulance services in this country, some authorities taken away intubation from pre-hospital clinicians and left it for critical care paramedics and doctors. Some authorities, like the one I work for, still keep the intubation as the skill for pre-hospital clinicians. In Poland, and I left this country in 2015, we basically intubated everyone. So like any minor thing like fractured finger, Bosch, tube down in, and no, of course I'm kidding, but yeah, it was widely practiced. However, I believe that it was mainly due to the economical reasons, because again, tube were I think it was like £2 per tube, whilst, or equivalent of £2 per tube, whilst supraglottic airway devices were significantly more expensive. I think it was 20 or 30 pounds per device. So yeah, we were instructed by our medical leads, use tubes because they are cheaper. But this way or another, intubation was and still is very popular in Poland, very common in Poland. What is the situation up in Finland, Timo?
So yeah, we do intubate. So obviously we have different areas, just like the UK, but the guidelines are pretty similar between them. So paramedics can intubate in all of the areas at the moment, but we do prefer to use the stepwise approach as well. So start with the mask and then the OP and NP and stuff like that. You can like change it up if you feel like the patient actually needs something specific, so you don't need to always go through the stepwise approach, as opposed to the UK. So that's really good. There's like a unwritten consensus about it. So if you know that the patient is not going to be benefiting from an OP, you don't need to fuff around with it. You can just use the iGel or intubate straight away. Then we also follow, obviously, the European Resuscitation Council guidelines. So if we know that the patient has a clear indication for intubation, for example, they've been submerged in water and drowned, then we would go straight for the intubation and not mess around with an iGel, because especially in the Finnish winter, it's not going to form up well in their upper airway. The patient is going to be very cold, and the paramedic is going to be even colder. So shaky hands, not going to intubate well. Then who does the intubation though? It's probably most of, if not all of the time, an emergency medical doctor. So we've got an extensive network of doctor cars and helicopters, and it would be very rare indeed to not get a doctor on scene in time to manage the airway with an ET tube. So mostly paramedics will use iGel as like a bridging maneuver if the patient needs an intubation, and very rarely intubate.
So you want to say that in Finland you may get a doctor within a couple of minutes?
We are like, yes, either we will get the doctor in a couple of minutes, or usually around the same time, or then the paramedics are not going to meet the patient in a couple of minutes, and the doctor has more time to get there. So yeah,
Okay, all right. Yeah. Okay.
Fast enough,
Let
I
me
would say. Yeah, mostly.
let me still remain quite skeptical, but fine, Mr. Steed.
So in Australia, broadly speaking, most ambulance paramedics cannot intubate a patient. So there are some states, Western Australia is one of them. And for those that don't know the geography of Australia, Western Australia covers probably about a third, if not more, of our land mass, which is quite large. But the population is very, very spread out. So ambulance paramedics there can intubate, but they can't perform RSI. So it's kind of just like cold tubes and that kind of stuff. But for pretty much every other state in Australia, intubation is a skill that's limited to the critical care paramedics or intensive care paramedics, whatever the terminology happens to be in that state. And it's been that way for as long as I can recall, even sort of way before I was in the industry. Now, as a sort of rough guide on the service that I work for, the ratio of intensive care paramedics to regular paramedics in terms of the units that are available, it's probably 10-1 ballpark. It can depend. Sometimes night shifts are worse, when there's going to be fewer intensive care paramedics available.
But if you think about
but-
distances, how quickly you can get the critical care paramedic or intensive care paramedic?
Well, it can really depend on where you work. So, I mean, even in a metropolitan area where I work, physically they might not be far away, or they might not be based far away, but there might not be any available for half an hour drive. If you're working in some of the more regional areas, they might be an hour or plus away in some instances. It's dependent on so many different factors.
So it
now
is
we
a
do
bit of
also
a
have-
gamble.
It can be. It can be. But generally speaking, I mean, as is the case broadly with EMS all over the world, is our caseload is getting lower and lower acuity as a general rule of thumb. And certainly in sort of my personal experience in the cases that I have attended, it's been very few patients that have actually really, outside of cardiac arrest and that have really needed like RSI. And for those instances where we have needed them, the crews have recognised early, or the intensive care paramedics have already been there and that's been performed. So it's very infrequent to be used and less frequent, again, for it to be needed and not available, typically speaking. So yeah, we don't have the doctors on road as in Finland, but that role taken up by the critical care paramedics.
And in terms of cardiac arrest, because I fully aware, and let me be very, very, very clear here, I'm not supporting RSI being given to paramedics at the moment with this level of education we receive. With all due respect to all my colleagues, clinicians, pre-hospital clinicians worldwide, I still believe that if you want to RSI, you need to get a proper training, and it should be more extensive training that we receive at the moment, even if you think about 3 years program. However, I still think about cardiac arrest situation. So what about cardiac arrests in Australia? Are you calling critical care paramedics, or
Yes, yeah.
you still want
So
them?
it may differ in other states, but in my service, 2 critical care paramedics are automatically dispatched to a cardiac arrest, whether it's one that's happened in our care or one that's come through dispatch. So they're automatically on the road to that for the purposes of intubation. And for those RSI purposes as well, if a patient is requiring intubation, it requires 2 critical care paramedics in most circumstances, and I believe most states. So not just one critical care paramedic, but usually a second critical care paramedic will need to be in attendance to perform the RSI safely. But it can vary depending on location, and obviously in regional circumstances, it's very difficult to attain that.
Are they on heli or are they on car?
Both. So
Okay.
the aeromedical, the flight paramedics train to a sort of higher standard again, but the road, what we term the MICA, the mobile intensive care ambulance critical care, they're on road.
Okay, cool. Thank you. That was United Kingdom, Poland, Australia, and Finland. Let's see now how things look in the United States of America. Let me jump across the ocean to Gina, Lori, Wendy.
Hello, my name is Gina. I'm with the United States of America here in St. Louis, Missouri, and today's topic is paramedics. Are they able to intubate? In the United States, yes, they are. Let's take about something like cardiac arrest. 98% of the protocols are going to tell you to go ahead and insert an iGel. Why? Because you're the medic. 98% of the time, you're going to be working with an EMT. Unless you're in a blessed service and you have 2 paramedics. Amazing. So with that being said, you would actually intubate that patient if you had the resources to do so. If you feel comfortable, if you have the training, then more or less you can do it underneath your scope of practice. You as a paramedic can intubate. But with that being said, you have to feel comfortable. And a lot of people don't, because they don't intubate very much, and depending upon what service they live in. So with that, you have to practice. People need to practice. That community or whoever they work for, that muni, that agency, they have to practice. And I'm not talking about like on a table with the mannequin. I need real life practice. Lay them down on the ground, because nobody's going to be laying on a kitchen table not breathing appropriately. So lay them down on the ground. Lay this mannequin on the ground. Practice like you're going to actually do it in real life. That's the key. Put them underneath pressure. Put these paramedic students underneath pressure. Put real paramedics underneath pressure. Give them real scenarios so that they could feel comfortable in that scenario and know that they can get that tube. Now, if you don't feel comfortable doing anything, no worries. 100% iGel, secured, that's great. But iGel is also a fasting tested product. So in the United States, we use it for the OR as well. It is a testing product on fasting patients. No food for 12 hours. But they don't realize about the cardiac arrest that had the chili cheese dog at Dairy Queen 20 minutes before that they had this cardiac arrest. So you actually insert the side gel, which goes in the actual esophagus and cups that epiglottis. Well, there goes that chili cheese dog right all over you. So with that being said, you do have to be prepared for that suctioning. And depending upon what the scenario is, you might even be able to insert an NG tube down the iGel. But for me, I primarily like intubation. But again, different scenarios, different reasons, different rules and regulations. I do not like iGels in pediatric patients. I do not like them. There's no securing device for the iGels here in the United States of America for anybody underneath the, I think, size 2.5. No. Maybe 1.5 and low. So pediatric devices in general, like I feel better with an intubation where I could see the actual airway secured, and then secure it with the actual tube holder and tape just in case, because a lot of times these fasting devices don't realize that the baby had formula 5 minutes before they went into cardiac arrest. There's no securing device. You have to jerry rig it, meaning like tape, like using the adult cuff but only cutting it in half, things like that. So you're gonna have to do that. And if you don't, and you don't know, and you're not educated, well, when that baby moves, there goes the iGel. So with all that in mind, please stay safe and have a great night. Thanks for watching.
That was quite interesting. They don't have an iGel holders or supraglottic devices holders in the United States. That's quite interesting. And also quite interesting point from this video is when Gina said that she's more comfortable with intubation of pediatric patient rather than shuffling the iGel down the throat whilst here in the United Kingdom. And I can see again Timo who worked with me for a couple of years. He made this face. Yeah, intubation of pediatric patients have been removed from paramedic scope of practice here in the UK more than 5 years ago. So we don't even carry tubes small enough to intubate pediatrics. In the United Kingdom, the smallest tube we carry is number 6, which is still quite a large one. And what was interesting, Gina mentioned about limitations of supraglottic airway devices. And I know that we had this conversation, Teemu, between us. What is better? Is it iGel or supraglottic device or actually intubation? But with all this, with all those, supraglottic devices are great approach, Mr. Silva. What are the actual limitations of the device? Because we know that they are quite quick to insert, but they have limitations.
Yeah, so obviously the limitations for the SGA, so the supraglottic airways, just as Gina mentioned, include obviously patients that are vomiting. Then, as I said before, patients that have drowned will often have foam and water and stuff in their mouths, and they will also be vomiting usually. Then also patients that are cold, especially if you're using nigel, it's meant to form up better if the patient is at least somewhat warm, and stick there better and provide a better seal. I've never used other SGAs myself, so I can't speak for like the older ones, like the larynx tubes and the larynx masks. We've completely switched away from them in Finland, so I've only seen them in pictures, not even in real life.
In museum.
Yeah, I know. I'm a bit younger than you, Alex.
Younger than me.
I guess that's pretty much it in terms of the limitations.
Let me stop.
Mostly.
Let me stop you here. I've got a list here. I've got a long list of limitations now, but with 2 most important limitations I want to mention, and to our viewers who are a bit skeptical about my approach to intubation and prefer to use supraglottic airway. Fine, just please open the user's manual for supraglottic airway. And for example, iGel, page number 7, iGels are contraindicated in sepsis, pregnancy, or any condition where the patient may have a full stomach. Again, that's a quote from user's manual, and I believe that if you use different supraglottic airway, there are more limitations to it. So please, if you use it, go to the user's manual. Don't just assume that it's just a simple device. Open actual instructions of use and read them carefully, because there are some limitations you may not be really aware. There's one more limitation, Mr. Silva. So if you think about ventilation, I'm sorry. If you think about ventilation of your patient with a positive pressure, if you squeeze the bag too firmly, and you will create a pressure that is greater than 20 centimeters of water, you will actually cause the insufflation of esophagus, and that's proven on cadaver studies. So how many times we have seen on the road clinicians who are bagging too firmly, too harshly, person who is on the supraglottic airway, and actually causing insufflation of esophagus involuntary, because we don't want to do it, but we are not aware of it. So the bottom line from me, at least, is please read the instructions. Even if you think that device is amazingly simple, I'm pretty sure that every medical device has limitations and contraindications, and you guys need to be really aware of it. The next thing I don't really like about supraglottic airway devices is the way that the fact that they don't have a proper securing system. So, Teemu, how do you secure your iGels?
There's a holder that comes in the package. That
you have the holders. Okay, no, fine. Yeah. If you have the holders, fine. We don't have the holders. We don't have holders at all. We just.
And then there's obviously the brown tape.
Oh, yeah, of course. or how we call it, trauma tape. Sometimes we think that the whole healthcare is actually kept together with this trauma tape. But yeah, some of the manufacturers, again, not mentioning any particular manufacturer, advise to secure the supraglottic airway with a tape. So maxilla device maxilla, which in pre-hospital setting, I would say it's not robust enough. What we do in the United Kingdom, at least again, authority I work for, is we use the cord. So cord from the back of the neck to the top of the eye gel, 2 knots down to the device, 2 knots, and back to the side of the patient's face, where you make a small what's the word, bow. And that's it. And again, it's quite robust. It keeps the device in place. However, there is a massive risk of the cord sliding down to the jugular veins, and including the jugular veins, which is quite significant operator error, but it happens. So that's why I don't think it's really great. Whilst with tubes, you may have two tube holders, and yeah, I think it's just more robust, isn't it? Okay, so any other limitations? Maybe Harrison, who sits quietly and just watching us having an argument.
Well, a discussion about the previous limitation and patients with full stomachs and like, are you guys routinely decompressing the stomach when you place an eye gel, like with an OG tube?
Nope.
Or no? Okay.
No.
Timu?
Yeah.
You are. Okay, Timu's. Okay. So, I mean, that perhaps might be a reflection of your service's higher reliance on eye gels, Timu. I mean, you've got the holders and you're doing the decompression as well. So maybe that's a reflection of, okay, we're not intubating as often, therefore we'll make the most of this device. So I suppose, yeah, like trying to adjudicate those arguments, it would probably have to be maybe a line ball there. I don't know. I'm very democratic in this. I'm trying to be as nice as possible.
Yeah. I think we're probably not going to go into it right now, but I have to say a discussion about limitations of SGAs is nothing without the discussion on the limitations of ET tubes.
Okay, what are the limitations? Come on, bring it up. Come on.
Okay, so the limitations, if you look at the, obviously, like UK, Finland, if we're looking at the European resuscitation guidelines, which are basically the Bible for cardiac arrest, intubation, or like airway management in general, they document a risk of unrecognized misplaced ET tube, and the chances range anywhere between 0.5% to 17%, with paramedics being more common to unrecognize the misplaced ET tube than emergency physicians. They also document a prolonged period without chest compressions when placing a TI tube, and the median for paramedics is 110 seconds of interrupted chest compressions. Yeah. Also, tracheal intubation accounts for about 25% of all CPR interruptions. There's a comparatively high failure rate. Intubation success rates usually, especially like in the PART trial, was 51%. And it has been documented for a long time. I know our special guest wants to get in on this soon. And it is a good discussion to have, because there are things that we can do to reduce the risk of failure when intubating and also make it quicker. And that is a fair discussion to have. But most of all, they document that the tracheal intubation is a really difficult skill to maintain and acquire. They have done studies on it, and some of them say that anesthetist residents required 125 intubations in an operating room setting before they were able to achieve a ET tube placement success rate of 95% under those optimal conditions. And that's not to say about the conditions in the emergency medical service.
Yeah, so just
So at
let's
the
take intubation away. Let's not even try, right? Let's just and
Well,
okay, Harrison.
Well, I think what Tim is sort of leading towards as well, I wanted to sort of add something. When we're talking about these studies and they analyze like the first part success and they analyze the time taken to actually get that intubation and the missed compressions. I believe it was the Curbside to Bedside podcast, an episode of them, that something stuck with me. And often we can't pretend that there are some services that are very good at certain things and some services that are not fantastic at certain things. And those services that are focused on education, focused on research, and focused on rigorous training and very good at their intubation, very good at their other skills, are more likely, typically, to be those same services that are focusing on research and putting out these sort of papers. So we've got to sort of consider as well, perhaps some of these numbers almost falsely sort of representing also the good services that are very good at their their ongoing practice and stuff. Whereas broadly speaking, there's plenty of services that are probably not as good. And when you look at some of the statistics worldwide, yeah, some EMS services have first pass success of high 80s, low 90s, and some of them are in the 50s and 40s and possibly even lower. And our special guest can probably speak to some of those statistics as well. So, yeah, I think like when we look at those, even in the numbers that Timu brought forward, it makes intubation seem quite risky. Is the risk worth the reward? But if we really need to sort of accommodate for everyone, go, well, yeah, if we're only getting half of our first tubes, and we're taking a minute or longer to do them and taking out from all those compressions, which we absolutely know is the most important thing. Is it worth it to sort of keep that skill?
But you know what I feel? I feel that we create a vicious circle here, and I don't mean us guys. It's just the ambulance service or services, if you like. Pardon me. So it's like, okay, so we have the intubation in the scope of practice. Then something happens. Let's say a serious incident. So we are suddenly trying to stop the training or at least limit the training, and we are trying to limit the possibilities for paramedics to practice, and we are trying to limit the intubation as such, and then we say, intubation fails because people are not good in it. Yeah, because we just stopped training. We just stopped the whole process, or we started to limit the process because something happened. So instead of trying to learn from the incident and instead of trying to be better, we suddenly said, okay, let's just take the intubation away and just put something in place which is fast, but it has lots of limitations. And I mean supraglottic airway, not mentioning any particular device. So I think it's time to introduce our special guest. Well, let him introduce himself. Paul, over to you. We don't hear you on mute, mate.
Thank you. This has been a very interesting discussion. I'm Paul Hagen. I'm one of the co-founders of Adroit Surgical, and we make and distribute and help people intubate with the V-scope, which is a device that mimics what ENT surgeons use around the world every single day in every single hospital, and we've kind of made it into a disposable device. So that's the disclosure. I'm pro intubation. I'm pro choice. I'm a guy that thinks that you should use the right device for the right patient at the right time, and I see the value. I've liked this discussion, but I have this deep-seated feeling that endotracheal intubation is one of the most valuable things a paramedic can do for that patient. I mean, you guys talked a little bit about the economics of it, but putting that 2-pound tube in You're helping the patient in the field for the transport. They're helping him in the ER, and then wherever else they go, whether they go up to the OR or the ICU. We all know we've seen this. If you put a supraglottic airway in, what does she do? What does that ER doctor do as soon as you get in there? They rip that thing out, they throw it on the floor at your boots, and they intubate the patient. So I think endotracheal intubation is the gold standard. I respect all the comments here. I think for some patients and some clinicians that don't have those privileges, I don't think you have to RSI everyone. I think you can intubate some of the patients awake if you're fast and gentle. So anyway, there's the disclosures. I'm with a company that is trying to make intubation and increasing first pass success. I think that there's the need for all kinds of devices, but I truly believe endotracheal intubation is the gold standard.
Okay, and what would you say about the first pass rate success rate? Because it is
so in the United States, we mirror all these statistics that you were saying, and let's just call it 50%, 51, 50%. That's what all the studies say. Unrecognized esophageal intubations, all those kind of problems are in the studies here in the United States as well. But what do we need to do? We want to go to something easier, so we're just going to eliminate it. I don't think so. I think it needs to be a tool in the toolbox. If you need to put in a rescue device, great. If you're in the operating room and it's a 15-minute procedure, maybe you can put in a supraglottic airway. But I think that we need to keep this in the scope of practice here in the United States, which contradicting some of these others. In the United States, we do have a national standard, but it's really governed by the 50 individual states. That still hasn't, the state medical director says what our rules are and who can intubate. So.
Okay, all right. So you mentioned about the tool in the toolbox that lets us intubate, and we traditionally use laryngoscopes, and we traditionally use Max and Millers for pediatrics and Max for adults, which is something I don't really agree with, because sometimes when you have a really difficult airway in adult patient, you may use large Macintosh blade, and it works really fine. Mm-hmm. I introduced you as a person who basically is changing at the moment. You are changing our view on intubation because of the device you basically introduced.
Sure. So, I go back to a fundamental question, and as I train paramedics and emergency room doctors, I'll ask you, why do we even use a laryngoscope? What are we doing when we use a laryngoscope?
You open the mouth, you shuffle the tongue to the side, and you create a leverage which basically lifts the tongue up slightly, which is not great.
Get a visual confirmation.
That's a better answer than I get most of the time. Most of the time, people tell me they're using a laryngoscope to get a view. And I think that's partly correct. I think your answers are more correct. What we're doing using a laryngoscope is to give ourselves a path. Mm-hmm. And what we've done that's a little bit different, taking from the ear, nose, and throat, the head and neck surgeon world, we're helping you intubate through a barrel. So when you're making that path, we're keeping that path open, and you can pass a bougie and intubate through a barrel. But I think that's a fundamental thing of the training. When is it indicated that we should intubate? We can have that discussion, and I think that's very, very important. But then when we have any of the tools, why are we doing that? What are we accomplishing with this, and how do we accomplish it?
So you basically want to say that the intubation through the barrel is far more effective.
Well, we've shown that. We've shown that in a few studies. I think that if you wanted to show the third photo, this shows we've documented one study, and we can put a link to it here, where we were able to get 93.3% first pass success rate
Yes.
after just a few hours of training. And this was a 45 live patient study. The paramedics were in full double PPE for COVID, and these were cardiac arrest patients. So Mack and Miller, they were showing 55, 60%. And then with our device, after a couple hours of training, they were able to show 93.3%. One of the things I looked at with this study was we got 100% after the second pass, and they were very new to using our device. The other devices that they used, first pass, second pass, third pass, and then I'm like, okay, what happened to those 3 patients? You know, they didn't even get a chance. The other thing that we were talking about, the training and becoming an expert. The other study on here is by Dr. Sakels at the University of Arizona, and this is what he's saying. And again, I want people to hear what Tim said about 125 patients before you become an expert.
Mm-hmm.
Here's something else that's showing that medical doctors, they are emergency room fellows, and on the right-hand side there, it took them to postgraduate year 3 before they became 90%, which is what they call an expert. 90% first pass success rate with the glide scope, and I don't even want to tell you the numbers there. Everyone can see it, how they are with DL. So, I mean, it's a difficult skill. We're trying to make it easier. We're trying to make the training faster and easier, learning faster and easier, and then actually using the device being faster and easier.
I must say, Paul, from my perspective, you and your team sent out a sample a couple of months ago, and I'm not an intubating paramedic, as mentioned. I haven't practiced the skill. I haven't been taught the skill, and I've played around with mannequins and tried to do it, and thought it'd be this isn't too bad, and obviously less than 50% on the mannequin for me. But when I received the apparatus that you sent out, it's quite intuitive. I will definitely say that much. And in terms of training, I think I watched one YouTube video and thought, I'll try it out on the mannequin, and it is quite easy, quite intuitive to do. Placing the bougie directly through the barrel, you've got the marked bougie there, so you can see exactly the depth that you're doing, and place the tube and sort of did all the checks, and obviously on the mannequin's got the exposed lungs, so you can make sure you're actually inflating. And I had a 100% success rate out of like 5 attempts from watching one YouTube video. Now, obviously these aren't real patients, but the discussion going back to, is the intubating skill too hard? That's why we've taken it out and gone to eye gels. And look, eye gels are the same thing. Plonk them down, and most of the time you're gonna get it pretty good. Like, I think there is merit in what you're trying to introduce here, and take out a lot of the difficulty around it, and almost maybe make it like an interim measure. So in some services that are not quite ready to take out intubation completely, but maybe sort of, all right, we'll drop back to this, or only have it for certain paramedics to use this V scope and see how it is. Because
that's a really good.
I found it quite good. Yeah.
Yeah, thank you. I mean, that's really good. I mean, that's what we're trying to be, as a tool in the toolbox for people. We're very blessed that we're selling now in 25 countries, and we're getting that kind of response. Some people are using it as a frontline device. Most people are thinking of us as a difficult airway device, which is fine. One could, we could have a whole discussion on what's a difficult airway, and anything in the pre-hospital environment outside the OR is automatically classified as a difficult airway. So you've got those kind of challenges here, but what does it take to be an expert? How much training do you need to do? The right tool. I think that we need to have a lot of options. And we're not going to get a disposable bronchoscope on an ambulance. So we're another tool in the toolbox. That's how we've been positioning it, and that's how we've been very, very successful.
What about
I wanted to actually, I wanted to talk about because I obviously also got the samples and I tested it out on a mannequin, and I also gave it to our EM doctors to try out and figure out what's what. We have a video laryngoscope in the doctor unit, and they ended up preferring that. But I would say it's because it's out of habit as well. They didn't use the V-scope on actual patients though, so there's quite limited opinion there. To be fair, what I found really weird is that we know from studies between direct laryngoscopy with a traditional laryngoscope and video laryngoscopy with obviously a video laryngoscope that the video is going to be easier, better compared to the DI. And then, for example, in my service, and I believe in all ambulance services in Finland, the paramedics, they get the DI scope and the doctors have the video laryngoscope, which is
Right.
really baffling to me because like why like limit the chances for the success by providing worse tools for the paramedics. And I find the V-scope to be actually a good tool for a clinician that very rarely has to intubate because you don't go through so many of them, so that the cost is barely there. And I find it a lot better than direct laryngoscopy myself.
Well, a couple people have called us DL 2.0. Some people have called us a poor man's video scope, even though there's no video component to it. We are definitely in that gap, and I think with the price of video laryngoscopes, they're going to be widely available in some services, but there's going to be other places that they are just not available. The prevalence in the United States pre-hospital is about 15%, so that's about 85%. They want video. They know they have a problem. They want some kind of solution, and we are kind of an alternative tool in the toolbox for that. And we fit right into the normal DL training protocol, which is also very, very beneficial to them.
What I really like about ViewScope is it's actually, as Harrison said, it's so intuitive, and you can start using it after like a couple of seconds, or even 1 or 2 YouTube videos. Speaking of YouTube videos, dear viewers, if you want to see the ViewScope in action, I will leave the link in the description below to the group call video where we actually test the ViewScope on one of the most sophisticated and advanced mannequins by LiveCast Body Simulation. Those mannequins are really difficult to intubate. One more thing about intubation, because this device, ViewScope, provides us with an opportunity to perform a paraglossial intubation, so intubation from the far lateral aspect of the mouth, which is, in my humble opinion, an amazing thing, and I would happily use it and promote it amongst the paramedic students who actually are taught intubation. Because again, in my humble opinion, the problem is that we suddenly stopped or limit the education options here, and we don't want to progress with education. We want to stop it. And again, are there any economical reasons behind it? I don't know. We just want to know what happens to the intubation and why intubation is so common in some countries and limited in other countries. Speaking of education, last question to you, Paul, because I know it's 1 o'clock now. It's nearly 2 o'clock in the morning now for you. So what type of education do paramedics in the United States have in terms of intubation? What type of education do they receive or training?
So, everything's governed by the National Register of EMT as well as the state medical director. But dovetailing back to, I believe, what Tim and what you were alluding to as well, many of our pre-hospital EMS were tied to hospitals, and they would get into the OR and they would get a lot of practice. That has stopped. They get their 5 minimum. We have a lot of cadaver labs. There is continual training on mannequins, but the cooperation between EMS and our hospital systems is fragmented in the United States, and people don't get the training the training opportunities on live patients the way we did 25 years ago, and that's a shame. And I would put it out to you guys who got some samples. If you got a cadaver lab, I'll send you another sample. Don't use the one I gave you on a cadaver lab and try and wash it. I'll send you a fresh one. And if any of your other viewers want to see this, try it out on a mannequin, I'd be happy to send them one as well.
I think in terms of training, the important bit to remember is that it is a zero-sum game. Like, we have limited resources, limited amount of money, and limited amount of time spent on training, and it needs to be focused on things that will make a difference in a wider population as well. So I could spend hours and hours and hours practicing IO access, but am I going to do it that often? Is it going to be beneficial compared to something else? Probably not. So I think what I really like about the V-scope and your approach to intubation is that it also brings down the required amount of training compared to direct laryngoscopy intubations. Because, like Alex said before about the ventilating with the back wall mask and people doing it in a wrong way, well, why not take the training from direct laryngoscopy, put it towards bagging a patient, because you're going to use the back wall mask more often than you're going to have an intubated patient, because you will use it on non-intubated patients as well. So you're basically double dipping on training there. But if you can train in a like a lighter fashion, maybe with the V-scope to do intubations, I think that's a good thing. It opens up space for other training as well. So yeah.
That's a really interesting study that we hope some people are conducting right now. That now that we've been out there, we've been selling, we've been using for 2.5, 3 years. Are we like riding a bike? If you've got the basic training on the V-scope, that 90-second video, a year later, if you haven't used it and you use it again, so hopefully that kind of stuff will be published as we continue to grow and expand. But the success rates that we're seeing on people with minimal training when they have to do it. I mean, I would love that a person train 5 times on a cadaver, 3 easy cases, and then they jump into a difficult cases. But some of these anesthesiologists that are using our device and emergency room doctors, they're doing their easy cases with DL, and then this is a difficult case. They're failing at DL. Hey, give me that thing that lights up that they gave me, and they're intubating. So I would love the continuum of training, but sometimes people jump some steps.
Yeah.
Yeah, and I think that's actually a very good point to finish this conversation. Before I will finish, I just want to say, guys, that we are aware of Airway 3 trial ongoing at the moment from the University of Warwick. We know that they are collecting data at the moment, and as far as I'm aware, they will publish the outcome. So IGEL versus or supraglottic devices versus endotracheal intubation in 2025. So we need to wait couple more years for the result of this study. But again, what I think personally, that's only my opinion, we cannot use study for everything, or studies or research papers for everything. We need to educate, we need to learn, we need to be better and better in our job, and that's would be my point. And also a bottom line from me, please, if you use any supraglottic devices or any intubation device, always read contraindications and always read when this device or this way of maintaining the airway is not required, it's not sufficient, it's not appropriate, I would say. Any messages from Finland or Australia before we finish?
No, not really. Nothing to add.
Good. Thank you, guys. Thank you so much for watching. Paul, thank you so much for joining us today on this very special episode of Group Call. Teemu Silva, Harrison Steed, Alex Hepner. Thank you so much for watching. See you guys next time.